Good morning. Welcome to another exciting episode of PI Today. This morning we have a very famous physician, Dr. Eugene Pahk, board certified neurologist. Thank you, Dr. Pahk, for being here today with us.
Thanks, Dr. Nick, for having me here.
It's going great now that you're here. So, Dr. Park, in the world of personal injury, we've had a few segments with pain management, ketamine treatments with Dr. Tamarazi. We've had psychiatry with Dr. Rod Amiri. And we know that it takes a few physicians to facilitate and treat traumatic brain injuries. The diagnosed part of it is essential for these patients to get treated. Kind of tell us about yourself, your background, your education, and tell us how you run your practice and what you're looking for. So we kind of gonna dive into how neurology and a neurologist practices, and please let us know.
Sure. I did my medical school at the Technion Institute of Technology in Israel. I did my residency at what used to be North Shore Long Island Jewish, but is now Northwell in New York, which is, if people don't know, a 26 hospital system. I was at the flagship hospital there for the course of my residency. Since then, I have been part of I do inpatient work at Mission Community Hospital, where I am faculty in the psychiatry program there. So I instruct residents and take care of patients within hospital. And I treat traumatic brain injury patients outpatient.
Wonderful, wonderful. And these patients that get affected by traumatic brain injuries, what kind of symptoms do they present with? What are you looking for when these things happen?
Well, the difficult part when it comes to traumatic brain injury, the brain does a lot of different things for any given person. So pretty much everything that we do, every action that we take, everything that we think, has its origins in the brain, and thus traumatic brain injury could really impact almost any part of your life or impact people in various ways. Now, most traumatic brain injuries, there are certain parts of the brain that tend to be impacted more than others, such as the cortex, with especially with acceleration deceleration injuries, just kind of like the outside layer of the brain. Definitely in the frontal and temporal lobes, at times the occipital lobes of the brain. So, long story short, what this means for people is that their presentations can be varied, but very commonly we will see problems with focus, attention, concentration, memory, some mood disorder problems as well, as problems at times in the vestibular system, which impacts balance, nausea, vomiting, vertigo. It can also impact vision and hearing. There really the list is very, very extensive, just because, as I said earlier, the brain takes care of so much.
Correct. And in our prior segments, we really focused on behavior and depression, um, and mood swings or impairments. Um, and of course, there is a, how do you say, a goodie bag of treating these patients, because a lot of TBIs, you know, it can be subjective, because the patient presents without a bleed, let's say, right? So some of the tests that we've seen to bring into more of an objective realm are certain type of scans, like spin tech. It's a sensitive DTI with different applications in order to create a good visual image for the radiologist to diagnose. What's your take on that?
So, long story short, brain cells, neurons, they can be very, very, very small. Pretty much the width can be on the order of microns, while your average MRI, even a 3 Tesla MRI, can really has a resolution of about millimeters. So maybe like, just about 1,000 scale off. more or less. So, it's a challenge trying to image cells that are so very tiny that conventional imaging can't pick up unless there's very dense lesions. And there's more recent technology, as you were alluding to. Diffusion tensor imaging has shown some sensitivity and promise. To a more limited extent, perhaps volumetric imaging. There's technologies further and further developing to address this challenge of imaging the brain to greater level detail to pick up these more subtle traumas. And these scans, it's very important to have scans of these quality with greater sensitivity, because so much of it is missed just with conventional imaging.
Correct. So that's one objective test, and of course everybody's heard about VNGs, and that's been around a very long time. Does that test make things more objective in order to be able to help to diagnose these patients with a traumatic brain injury?
Yeah, it's unquestionably objective in that there's nothing that a patient can do for the most part to throw off a VNG result. It's really just testing the vestibular function in the nerves. Now, keep in mind that negative tests for each of these does not necessarily even exclude TBI. These tests don't catch everything, but when they do, they certainly could be objective evidence of some kind of neurologic dysfunction. And in the absence of other neurologic conditions or other issues, it's a good marker or good objective finding that could be indicative of TBI.
And how well do you go in parallel with, as far as behavioral therapy, we're referring to psychology PhD for talk therapy, and psychiatry MD for med management therapy? How important is that when you see a behavioral deficit?
I think it's of paramount importance, and the reason why is, these symptoms are very often overlooked, unfortunately. But, well, I could tell you, sometimes these behavioral deficits, they can be somewhat subtle, but, well, I guess people should kind of ask themselves this personally. Say you were all of a sudden just an angrier, more irritable, more discontent, depressed person. You spent pretty much days, weeks, months on end just absolutely miserable, making your friends miserable, making your families miserable, and just kind of ruining all your relationships. These things can happen with traumatic brain injuries in a number of different ways. And it's also unfortunate that these symptoms are so often missed when patients do have these injuries. So definitely identifying it correctly, managing it correctly can be life-saving, ultimately.
Fantastic. And normally, do you see the patients on initial consult and then they follow up with you as their treatment with other physicians or other providers progress? Do you assess them and see how basically they're getting along with their treatment?
Absolutely. Taking care of a patient, it is definitely a team game. We collaborate with other physicians in order to ensure every facet of the patient's care is optimized and taken care of. So definitely, just observing them over time, observing their improvements, just trying to ensure that nothing kind of falls by the wayside is, once again, absolutely necessary.
Absolutely, it's paramount. What about these more severe patients where they need inpatient care? How is that diagnosed? How do we know who needs it, who doesn't need it? And what does inpatient care really consist of, depending obviously on the patient's diagnosis?
Yeah, and ultimately there is some gray area when it comes to this particular area. Different people have different thresholds for recommendation of inpatient rehabilitation and more intensive care. Personally, what I look for is a significant disruption to the patient's life and livelihood.
Yes, exactly.
That if they do not recover quicker, If they do not recover to a greater degree, then it could have long-term consequences for their life and livelihood. And and there is some there's some room to argue there. I've recommended patients who, certainly people who are not functional, people who have significant cognitive difficulties,
Speech issues.
speech issues,
Yes.
just just inability to move. Of course, there are major deficits that would necessitate that kind of rehab, because people can't, in that kind of state, probably can't even take care of themselves appropriately. But even, I'll say, in some cases, people with demanding jobs, people who are very high performing and can't perform at the level they normally perform, do very critical work. Um, even even though they can seemingly take care of themselves, they that lack of ability to perform, and their inability to wait for that kind of improvement sometimes necessitates inpatient rehabilitation.
Correct.
And inpatient rehabilitation in general, well, outpatient rehabilitation tends to be more limited in terms of the amount of times a week. Generally, it's done in a more subacute basis. Your goal there is that you get better, but you get better over a longer period of time.
I got you. That's correct. Now, TBI was traumatic brain injuries was basically kind of, I guess, about 15, 20 years ago, was a little bit dismissed. Then that movie came out with Will Smith and CTEs. And we're seeing direct correlation to dementia and Alzheimer's and these type of problems with traumatic brain injuries that, you might not see the effects of it, while let's say you're in a PI case, in a personal injury case. But as far as the future goes, the brain is very mysterious, and these moderate to severe traumatic brain injuries can allude to dementia or Alzheimer's, as research has shown. Can you elaborate on that?
Yeah. Ultimately, there's more coming out research wise. There's a lot of good studies out there where a lot of progress is being made. Research is slow. That's just the nature of research. It's difficult to conduct. It's expensive. More and more is coming out. There is very well established evidence when it comes to moderate and severe brain traumas that there is a high incidence of future dementia, probably at a rate of at least 2 to 5 times the normal population.
Wow.
At least.
Wow.
Even mild brain trauma, it's actually, there's some debate there. There are studies for and against that, but there's more studies coming out. But there's reason to believe, to even suspect that that mild brain trauma can also increase the prevalence of dementia. Now, it's these studies, like I said, they're hard to conduct. Hopefully, more and more research will come out over time that will further elucidate that. But it's definitely something that's been underdiagnosed, kind of swept under the rug, and it's something that definitely has significant morbidity and mortality.
Wow. And it's unfortunate because it's something that in the personal injury world, obviously we have the privilege as doctors to treat these poor souls that have had traumatic brain injuries. But the access to care and their future is kind of limited, based on their injuries, and this is because of the unknown, right? So 20 years from now or 10 years from now, they develop dementia. This is a huge factor for these poor souls who, basically they were going on their day and something happened to them. It needs to be looked at even further. Now, when does how do you assess improvement in patients, and or decline in patients, as the quarterback, as the neurologist that looks at every doctor's report, what they've been doing out there? How do you assess these things?
Generally, like I said, it's a team effort for sure. And, for various different systems like musculoskeletal, pain management becomes very important. And seeing how, and, with at times chiropractors or physical therapy, that's very necessary to see the physical improvements that people are able to make in terms of, the degree to which they can walk, do activities, engage in exercise without adequate distress from pain and other issues. Definitely, it's just psychiatry and psychotherapy very important for ensuring that the patient is well taken care of from a psychiatric or mood
Absolutely.
perspective. Vestibular rehabilitation and VNGs. Like I said, VNGs are a little more or a little more objective. So, with subsequent evaluations over time, you can kind of see improvements over time. But it certainly does involve, like I said, it's a team game. Different people making sure different aspects of the patient's care is taken care of. Yes, and just following and collaborating with others is necessary there.
And when you see some patients that med management is absolutely necessary, what are some of the medications that somebody with a real moderate to severe traumatic injury that might benefit from if you saw necessary?
Yeah, and in this case, it does differ from patient to patient, and it depends on what system that we're talking about, like which symptoms the patient's dealing with. Psychiatry, of course, they have their own medications, generally involving SSRIs. There's from a headache perspective, there's a few different medication options there when it comes to sumatriptan. At times, cervical injections for cervicalgia, and occipital nerve injections as well. There's other, of course, medication options there. At times when people have very bad executive functions and need improvements in focus, memory, concentration, at times different therapies such as methylphenidate might be necessary. I could go on. Unfortunately, for every given system, there's different medications that can be helpful and that can help the patients improve.
Well, thank you, Dr. Pahk. This has been very enlightening. Thank you so much for being our guest today. We got the gist of what a neurologist does in a traumatic brain injury for their patients, and basically referring out to other physicians that the patients might benefit from. It's a pleasure having you here today, and thank you for all you do in the personal injury world. Thank you for seeing these poor souls, and we'd love to see you back on our show. Thank you very much.
Sounds great. Take care.